welcome to Health Talk. I'm Kimberly, and today we're going to be interviewing Dr. Gloria Wu, ophthalmologist and retina surgeon. Today we're going to be discussing the leading causes of blindness in America. Dr. Wu, what is blindness?
Blindness is defined in America as seeing the big E. If that's the only thing you can see, that's called legal blindness, and that's when you can get various help from the federal government and aids defined just for people who are legally blind. Now, the three leading causes of blindness in America, number one is glaucoma. It affects all ages. It can start as early as babies, congenital glaucoma. And then the next one is for working age Americans, it's diabetic retinopathy, when diabetes affects your eye and the retina, which is the inside lining of the eye. So here's the eye, and the inside lining is the retina. And that's when things happen in diabetes. The third leading cause of blindness again affects the retina, the inside lining, and that's age-related macular degeneration. That affects people who are over age 55. And what happens is that over a lifetime of sun exposure, UV light, we didn't really realize until the early 1980s that UV light was really powerful. And they did a study in Baltimore looking at fishermen, and they found out that they had changes in their retina that led to age-related macular degeneration. It was a landmark study. And what happens is that in the retina, which is a nice layer inside the eye, it's like the film inside the camera. So you need the film inside the camera to be nice and smooth, the surface to be nice and smooth. So each light ray that hits it would come back, and then you can see the image. What happens is that underneath the retina, there's little bumps. And what happens is that the byproducts of metabolism, metabolizing sunlight and all sorts of light over long periods of exposure, especially if you're a fisherman, you're an outdoors person, these products of metabolism sit there. Your eye can't metabolize it. So it creates scar tissue and then bleeding. So it would burst open into the retina and cause these big bleeding vessels. So since 2006, we've been very lucky. We've had treatment for it, made by Genentech. It's called Lucentis or Avastin, ranibizumab, and we inject in the eye, and we virtually have cured this problem. And we're very, very happy about how we as ophthalmologists have been given the tools to really help people see. So blindness still can occur, but we're very lucky in America that nobody needs to go blind anymore if you go to an ophthalmologist.
Interesting. So after you are diagnosed with diabetes, when should you start seeing an ophthalmologist?
Now, once you're diagnosed, some people say that once you're diagnosed with type 2 diabetes, that's the type without the insulin, that you may have had it for a little while before, like a year, 2 years, 5 years. Some people say, oh, my blood sugar is borderline. But meanwhile, when it's borderline, you're really clicking into that pathway of becoming diabetic. You're pre-diabetic. So changes are happening in your body, and it's happening in your retina already, even though you didn't see anybody to document it or take pictures of it. So probably it's good to see somebody. The American Academy of Ophthalmology is very conservative and says after 5 years, after 10 years. But we in California, depending on the population you see, if you see a lot of people who are immigrants from different parts of the world where they've had no care, and they come here for the first time, are diagnosed with diabetes, sometimes they have severe disease already. People have come into my office with bleeding in their eye, and they don't even know they're diabetic. I'm the one that makes the diagnosis because they had no care.
How do you treat this bleeding in the retina?
So what happens is that when in diabetes, if you have high blood sugar, if you take the cells that make up the blood vessel and you put them in a petri dish, if you put it with normal blood sugar levels, you just pour blood with normal glucose level of 100 milligrams per deciliter, those cells are okay, they can live. But if you pour blood with 160 milligrams of deciliter of glucose, so it's a higher glucose concentration in the blood, those cells die. So what happens, the pipes that make up the blood vessels in your eye leak. They have cells that keep dying. So if you have a leaky pipe, the blood is carrying the nutrients and the oxygen, isn't going from point A to point B. So these holes, so therefore parts of your retina is not getting any oxygen or nutrients. So parts of your retina is dying. So big blots of your retina is dying. And what happens is that your body creates new abnormal blood vessels, and that bleeds. So what we do is, if it's only a little bit of blood, we can laser. We can now use ranibizumab, which is made by Lucentis. That's been just approved October of 2012. And then if it's a lot of bleeding, we may need to do more laser, or it's so much bleeding we can't see. And we would do a vitrectomy, where we would do surgery. We do, there's no scar. We'd make a very small incision, approximately less than an eighth of an inch, inside 3 little incisions. It's like super microsurgery.
Yeah, very small.
And then we suck out the blood, and then we laser in the operating room.
Oh, I see. So another cause is glaucoma. What are some symptoms?
This is a very good question, because, as I said, it occurs all ages at babies.
Right.
So if the baby is born with a very, very bulging eye, it's called congenital glaucoma. And that used to be called ophthalmos, because the Greeks in ancient literature even noticed it. So that comes with a gene. It's a genetic defect, and now we have gene testing for it. So that needs immediate surgery. But for other people, it's like sometimes people get glaucoma at age 12, again rare. They have associated diseases like juvenile rheumatoid arthritis. And then more commonly, people get it as an adult after age 40. There are 2 types of glaucoma. When you get it as an adult, there's no feeling. You feel fine. There's no pain. So most of the time, it's called open-angle glaucoma, and nobody has any feeling, pain, or anything. You feel nothing. You just gradually lose vision from the side. And gradually losing vision from the side is so little each year that you don't notice it. So it's painless, progressive loss of vision. So it's like the silent thief stealing your vision very slowly.
A little bandit.
Yes. So that you need to see an ophthalmologist or an optometrist. Now, a second type of glaucoma is angle closure glaucoma. So there are 2 big categories. So it's like being a red state or a blue state. So if you have open angle or closed angle. Closed angle is less common. However, it's more common in people who never wore glasses. It's common in Asian populations where the eyes are smaller. And then you have acute pain, sudden onset of pain, nausea, vomiting, the worst headache of your life, and you cannot see. You have about 6 hours before you lose all your vision. So it is an emergency. It's one of the emergencies that all ER physicians know about. It's tested on their boards. However, it is still missed because some people think, I have pain, nausea, and they're vomiting. They go to the emergency room. The emergency physician thinks that it's acute appendicitis. So they go through that road of blood tests, and meanwhile then they have eye pain. They ignore the eye and they start opening up the abdomen. And this has happened. This is common. And so sometimes it's still missed because people don't see it so commonly. We see it because we're trained, and that's what we see. I saw one last week.
What happened with this patient?
She had heart surgery, and she was in a well-known hospital in Northern California. And what happened is that after surgery, when she recovered in the recovery room and in the hospital bed, she said, my eye is red and I have pain, and she's vomiting. So the nurses felt that she was vomiting, gave her anti-vomiting medication because of the anesthesia. She was only 76, but she was, they thought she was just this innocent little old lady, nothing, she was just post-op. They gave her eye drops and treatment for red eye conjunctivitis. For 7 weeks, she had painful red eye, and it turned out she had angle closure glaucoma and lost all her vision. It's hard to get her back.
Do you treat this angle closure glaucoma with eye drops as you would with
What happens is that we catch it when they come in and they have this. We give them eye drops and pills. And there's also stuff to drink, which
Okay.
serves like a stronger elixir. You can give IV medicines as well. So it's treatable, and we can lower the pressure very quickly. If not, if we can't lower the pressure within a few hours, we go to the operating room.
So when you're diagnosed with acute closed angle glaucoma, what is a prognosis once they treat it?
They do very well.
Okay.
We get them back to 20/20 or 20/40 vision
With the eye drops.
with eye drops. But now, and we have to do an opening, a laser opening.
Okay.
Usually after the immediate treatment of eye drops and pills, we do a laser opening. So what happens is, here's the eye. Angle closure means that here's the lens, which is right here. And what happens is that the blue part or brown part of your eye is pushed forward in angle closure. So this part is pushed forward. It hits the cornea, and it's really painful. So what we do is we lower the pressure. Here's the little opening here, the trabecular meshwork that sucks the fluid in and out every 20 minutes. That gets closed because this is being pushed forward. And while we lower the pressure, we get the eye quiet and less pain. We then put an opening, a little hole here, so the fluid can go in and out more easily and bypass this little opening. So they're usually cured forever, and they may need drops and may not need drops. They may be fine without drops the rest of their lives. And usually their other eye is at risk, so usually at a later date we would do laser in the other eye.
So someone who thinks they have glaucoma and it doesn't run in their family, can they still be diagnosed with glaucoma? Or is it only hereditary?
They think there's a hereditary component because obviously they found one gene for congenital glaucoma, and I'm sure there will as we study the human genome more, but there is a hereditary component, but it's not like autosomal dominant, like everybody gets it, or skips a generation, like in diabetes, because sometimes diabetes skips a generation. So if you don't have a family history, you can still get glaucoma, yes, because you could have comorbid conditions. You could have diabetes that'll push you into glaucoma. You can have other things that make you prone, like collagen vascular diseases, rheumatoid arthritis, things that cause problems in the eye, colitis. If you get uveitis, what happens is, here's the eye again. If you get collagen vascular disease, lupus, rheumatoid arthritis, all the various things that give you joint pain, it causes little cells to be released from where the iris is. It's called the uvea, UVEA, and these cells are very inflammatory. It causes a reaction. So it causes this angle to clog up with cells, and so you get a uveitic glaucoma. So you can get glaucoma even though you never had any family history of it. You can also get glaucoma in young people. They get hit in the eye for any reason ever in their lifetime.
So traumatic glaucoma.
Right, and they get this maybe 20 years later. They forgot they got hit in the eye, they forgot they got a black eye, and then at age 46, one eye pressure is 40 and the other eye pressure is normal.
So why does it show up so late in life?
They think it's degenerative. So number one, in like people who got hit in the eye at age 6 and then they get it at age 40, when you hit the eye, goes kaboom here, these structures don't like to be hit because these structures are very small. They're all like 250 microns, 300 microns. So a hair is 50 micron. So the diameter of 6 hairs takes very little to blow on 6 hairs. So it sustains scarring, and the drainage, this little trabecular meshwork, this little tiny hole there, is scarred and it's prone to it. So by age 80 years old, this is not functioning that well anyway. Scientists think that the cells that make up the trabecular meshwork just collapse, so there's degeneration. So that's why sometimes you're on maximum glaucoma medications and it won't work for an 80-year-old. They've been on it for 20 years, since age 60, but eventually it just doesn't work and they need additional surgery. And lastly, they now think in the last few years, last 5 years, that the optic nerve is a big role, that they think this just degenerates. They call it a degenerative disease of the optic nerve. So they now lump it in the whole category of neurodegenerative disease, like Alzheimer's, because they feel that this nerve, which is part of the brain, loses cells and that the blood flow is abnormal. And the reason that ophthalmologists and retina specialists, I'm a retina surgeon, we still see people like this because they don't know if the optic nerve is abnormal, and we see a lot of optic nerve anomalies, or it's glaucoma, because sometimes you could have a 20-year-old have a very abnormal looking optic nerve, and we're worried about glaucoma, whether it's just they're born like that or it's something that they have early glaucoma.
When you have glaucoma and you damage your optic nerve, is there any way to recuperate those damaged or dead cells?
They're talking about it. The last 2 years, companies in Canada are trying to create medicines to work on protecting this. And there's one eye drop, bromidine, that they did tests on laboratory rats, and they found that it protected they increased their optic nerve flow. And so it's theoretical, and we sometimes try it in patients, and it's only an eye drop, but people are worried about how to protect this. And we find out that we do automated computerized visual fields that measure how much vision you lose in the periphery. And we find that surprisingly, over time, people's visual field get better. And so there must be some capacity for the optic nerve to regenerate, especially if you're only 40 years old, 50 years old. And it's very interesting. That's a big area of research.
So on the topic of age-related macular degeneration, how do you diagnose AMD?
Well, usually people come in saying, I can't read the newspaper, there's something wavy, or I can't pass the driving test, because driving is very important in California. It's important to all of us in America. It's a big country. Everyone owns a car. And everybody wants to drive. And it's a form of independence. So they're very afraid once they can't pass the driving test. And they go to their optometrist, and glasses doesn't help them. They still fail the driving test. So then they see one of us. And what happens is that they come, we take their vision, and then we dilate their eyes with the eye drops, and we look inside the retina, the inside lining. And now we have very fancy testing at all our offices as retina specialists, where we can measure the thickness of the retina, so we can see up to 25 to 35 micron resolution, which is impressive. So we can see each of the 10 layers of the retina and what's wrong. So we try to figure out what's wrong, and then we take photographs, we show the patient what's going on. Now, sometimes everything looks pretty good, and then we do the test where we're looking at the thickness of the retina, and we see little bumps, little excrescences, little bumps where it's not supposed to be, and it's at a point where we know that that's where age-related macular degeneration occurs. We then do something called a fluorescein angiogram, and sometimes in combination of an indocyanine dye test, green dye test. And that test shows us all the layers of the retina, and the indocyanine green dye test shows us what's the lower layers, the ones even deeper. So if you imagine your eye as a room, and you're standing in the middle of the room, so we imagine that we're lying down, and here's the eye, we're standing here. We're standing right here. Where you're standing is called the macula, which is the Greek word for spot. That gives you 20/20 vision. So you're standing there, and imagine where you're standing, instead of being nice and flat on this linoleum floor or this rug, you're rising on this mound of blood. It's just rising. So you're being elevated in this air with this growing mound of blood. That's age-related macular degeneration. So this mound is growing slowly, and sometimes it bursts, and then you suddenly lose vision. So not only do you have wavy vision, but suddenly it goes really bad. You go from 20/40 vision, 20/60 vision, to suddenly the big E. And then you have to go to an IMD right away.
To get it treated.
Right. Then we definitely would do a fluorescein angiogram, ICG dye together, and would figure out what's going on, the extent of the disease, and we would now probably treat you with the Lucentis or the Avastin treatment, which is ranibizumab, and we inject monthly injections 3 times minimum. And people have amazing results. They will get their vision back, but you can't wait. You can't wait
You have
till
to show up.
you've lost your vision for 2
Right.
years. Then we're talking of a struggle. We can still get you back some vision, but it's not going to be, next 3 months.
So after you do the fluorescein angiogram and the indocyanine green testing, how fast do you know if you have AMD?
You know by that exam 6 minutes later.
Oh, very fast.
Because what happens when we do the dye test, the fluorescein dye or any of these dye tests, you inject in the arm, it goes into your eye by 12 to 15 seconds. And it's a video monitor, so your doctor will be watching it in live time, and they can show it to you again, replay it for you. This is like football, instant replay. And you'll see each layer, and you'll see this area of growing blood vessels expanding, growing.
So I was reading and I found out that there's 2 types of AMD. Dr. Wu, explain to us, what are the 2 types?
There's wet and dry. 90% of the people with age-related macular degeneration have dry, but they don't tell you that at any time, dry can become wet. So you're standing in this room, in the macula, where I said you're standing in this nice flat linoleum floor or this nice rug. So you're standing on a bump. Okay, here's a little bump.
Okay.
You're used to this bump. You had this bump for all your, since age 55. Suddenly, this bump erupts, and you have this spray of blood in your room.
No.
That is wet.
Okay.
So we don't know when. It's a walking time bomb. We don't know when. That's why you have to show up at your ophthalmologist office, 4 times a year if you have already a mound. If you have no mound, and the mound that is not where you're standing on the linoleum floor, but by the mirror on the wall, we would probably see you twice a year.
Oh, okay.
Because that's not where the macula
So less
is.
risk.
Less risk. So then this mound can stay like that and just grow another mound. So you're standing on the linoleum floor, spot X, and you get another little mound there next to you, and it could stay like that. But then at any point, you get bunches of mounds. So let's say the linoleum floor is no longer nice and flat, but you get these little pie-shaped things sprouting up, these little mushrooms all around you. So we have to watch that. Once that happens, you're going to read the newspaper, and you're going to see the San Jose Mercury News. The headline will be big and nice and okay, but you start reading the fine print like, October 26th, you're missing the O or the 6, and you start consistently missing that. That's because little pie-shaped little mounds are
appearing.
Yeah, little mushrooms are appearing. So you got to check in with us. They will give you something called an Amsler grid. My office, you can go to my website, justforeyes.com, Amsler grid, A-M-S-L-E-R. You can go on the web, Google it. And it's basically just black and white graph paper. You cover one eye. You look at that center of graph paper. If lines are missing, see us. You cover the other eye, the same thing. So you have to see us. That's an Amsler grid. A German physician, 1850s, he created this. It's testing your visual acuity in another way. So something like this, you should not wait. You shouldn't say, oh, these little mushrooms appearing around me in this little linoleum floor is okay. Don't. It's your vision.
Do you treat dry AMD?
Now we suggest for them, depending on their age and their health status, high blood pressure, anemia, everything like that, we give them something called the AREDS formula, A-R-E-D-S formula for treatment. It's either Ocuvite, O-C-U-V-I-T-E, or iCaps. Those are the most famous ones. And they suggest twice a day. Now, in my very advanced elderly over age 80, I do not do twice a day simply because I worry that the high zinc is too much for them, especially if they may have anemia and they start bleeding, and they really start bleeding. They get big blotches of blood all over.
So anybody from any age, can they take these eye vitamins?
People ask me this all the time. I have 20-year-olds asking me, if you don't have the disease, don't take it.
Okay.
Don't buy something you don't have. Don't buy AMD if you don't have to buy it. What happens is that those vitamins are fat soluble, so they don't come out of you. Vitamin C comes out of your urine every day. So you can take tons of vitamin C, drink water, it comes straight out. In those vitamins has vitamin A and E. They do not come out. They stay in the fat compartments of all your membranes all over your body, your heart, your kidney, your liver, your brain membranes. So we don't like young people, they should just take a multivitamin. The eye caps and the Ocuvite, that formula, AREDS, and there are also generics of them. You have to read the fine print, you have to see what they say, and you have to ask your doctor. Even though it's over the counter because it's a vitamin, vitamins are unregulated. You can own a vitamin store and sell anything you want and say it's a vitamin. So you have to be careful. So if you have, ask your doctor. I would not just, be 22 years old or 35 years old or 40 years old and I say, I'm going to do this to prevent my eyes from getting it. Don't do it.
Don't treat something you don't have, right?
Right.
So when a person lives on their daily life, what are some tips that you give as a retina surgeon to avoid even going in the direction of AMD?
I like to tell them to eat one large carrot a day.
So it's true what they say about eating the carrots.
Right. Your grandmother was right. Your grandmother's always right. And because it has vitamin A, you can't overdose on one large carrot. That vitamin A you will process. I do not suggest eating polar bear liver because that has a lot of vitamin A, and some people will get toxic. So, but one large carrot a day will keep the doctor away. Try that. And the apple.
So, Dr. Wu, I see that you're working on this new little device, the glaucoma ball.
Oh, we created this glaucoma ball. This is 2 centimeters in diameter, the size of the ball of our eye, and this measures 40 millimeters of mercury, which is the high pressure of angle closure glaucoma. And I've seen this in the ER. I cover the ER all the time, and they call me, and people miss this. So if you touch your own eye, close your eyes, my studio audience and everybody out there, pretend, take your fingertip, close your eyes, touch your eye, and then you touch this ball, and then this ball is hard, and then you touch your eye. If your eye feels like this and you have pain, nausea, go to the eye doctor. We want to train nurses, and we want to train people in rural areas, nurse practitioners, people in different countries like Asia, India, where there is no health care in the villages, that this is preventable, and especially in Asia where they have smaller eyes and that they're more prone to this, that they can feel this. And I think that the lady who I saw this week, the 76-year-old lady in this hospital, if their nurses had known to feel this and just to touch her eye, because we're taught to feel lumps, feel bumps on your hand, feel bumps all over, to treat yourself for breast cancer, how we have the self-exam.
Right.
That if they could feel this, they would really help.
Wow. Okay, so in closing, now you studio audience and people all over know what are the leading causes of blindness in America. Make sure you see your ophthalmologist. Don't cancel your appointment. Please show up, save your vision. Tell your friends to go to the ophthalmologist. Thank you, Dr. Wu, for being with us today and discussing your eye knowledge. Thank you.